Good morning. I'd like to welcome you to today's conference, Perspectives on Climate Change and Public Health. I'm Ricky Revesz. I'm a professor and the former dean at NYU Law School, and I direct the Institute for Policy Integrity, which is hosting this conference, along with the State Energy and Environmental Impact Center. I'm delighted that so many of you are here online this morning, though I wish that times were more normal and we could get together in person. The Institute for Policy Integrity has hosted an annual fall conference each year since our inception in 2008 in order to spur conversation on policy issues that we see as especially timely and important. We're delighted to work with the State Impact Center to convene today's event. It was so wonderful to get to plan this conference with my NYU colleague, David Hayes, who has played such a leadership role on these issues over several decades, with Melissa Hoffer of the Massachusetts Attorney General's Office, who is such an important figure in the very successful efforts by state attorneys general to fight the destructive policies of the Trump administration, and with Dr. Stuart Harris of the Harvard Medical School, who has taught me so much in recent months about the power of narratives in the climate change area. As our enormously distinguished speakers will discuss today, it is crucial for scientists, policymakers, healthcare professionals, and advocates to pay far greater attention to the threat that climate change poses to public health. Even though the pernicious effects of climate change on public health are staring right at us, opponents of regulating greenhouse gases have over the last decade pushed a false narrative that environmental law has taken a wrong turn in concerning itself with climate change as opposed to on environmental problems that have public health consequences, such as air and water quality. But they then oppose regulations to protect air and water quality is a topic for another day and perhaps another conference. Those of us who regard climate change as the existential threat of our times have not done a sufficiently good job in making the case that the distinction pushed by climate change opponents is spurious. The effects of climate change are very much effects on public health. For starters, consider the injury asserted as the basis to gain standing in Massachusetts versus EPA, the landmark case in which the Supreme Court held that greenhouse gases are air pollutants for the purposes of the Clean Air Act. The asserted injury was that Massachusetts would lose coastal lands, not that increasing heat events would lead to additional hospitalizations, increasing the pressure on public hospitals and cost of the Medicaid program. Or consider all the attention that environmental organizations pay to the possible extinction of polar bears as a result of climate change. Think how many of us have gotten powerful fundraising appeals based on images of polar bears. Obviously, we should be concerned about the possible extinction of polar bears and other fauna and flora, but we need to pay considerably more attention than we have until now on the effects on human mortality and morbidity. There are experts who can tell us whether money could be raised with images of diseased lungs or people on ventilators. We need to drive the narrative and not allow the narrative to be dominated by climate change opponents. By the time climate change became a visible issue in our consciousness in the 1990s, we were already operating under a significant disadvantage. US environmental law, despite all its successes, suffers from an original sin: the very broad grandfathering of existing sources from the stringent standards of the Clean Air Act. The result is that coal plants that have been close to obsolete in the 1970s have continued to operate well beyond their lifetimes. In some cases, they're on their third lifetime because they didn't need to invest hundreds of millions of dollars on scrubbers like new plants. I explore this issue in a book, Struggling for Air, co-authored with my policy integrity colleague, Jack Linke. And opponents of climate change regulation have seized on a human narrative that turned out to be quite powerful: displaced coal miners. They ran the 2016 presidential campaign in significant part on a war on coal rhetoric, despite the very tenuous connection between the plight of coal miners and environmental regulation. And to further extend the life of obsolete plants, opponents of climate change regulation are trying, as we speak, to attack the reliance on indirect benefits or co-benefits to justify climate rules. The opponents understand, of course, that most climate change regulations, in part by shifting energy production away from coal, have enormous co-benefits in the form of particulate matter reductions and want them to go away. Our goal is that all of us come to see today at 1 p.m. not as the end of a successful conference, but as the beginning of an ambitious effort to effect a significant repositioning of how climate change is framed in public discourse. For those of you who are not familiar with Policy Integrity's work, we are a nonprofit, we are a non-partisan think tank dedicated to improving the quality of government decision making. We engage in research and advocacy in the fields of economics, law, and regulatory policy. And we bring our expertise to bear principally in the environmental, climate change, and clean energy fronts. For instance, our research and related advocacy on the social cost of carbon has helped make the benefits of climate change policies more measurable. We have published several important articles, including one co-authored with Nobel Prize winner Kenneth Arrow, and have led a coalition of major environmental groups in submitting comments encouraging the use of the social cost of carbon in all federal regulations that affect greenhouse gas emissions. Our most recent victory took place in a California federal court, which overturned the repeal of a methane emissions rule because the Trump administration applied improper, unsupportably low social cost of carbon values, failing to consider the full climate impacts of the methane rule's rollback. We have also worked to promote intelligent energy policies at both the state and federal levels that properly account for the benefits of reducing both greenhouse gas emissions and conventional air pollution. A great deal of our research and related advocacy has focused on the health implications of air pollution regulations. And we've taken a strong position defending the role of co-benefits against the spurious arguments to the contrary raised by the Trump administration. The Trump administration's disregard for public health has been especially pronounced in recent months during the pandemic, and we've worked to call attention to the policy failures that must be addressed. In this connection, over the summer, we published a report that looks closely at the connections between the administration's deregulatory agenda and the impacts of the pandemic. Weakening our defenses, how the Trump administration's deregulatory efforts has exacerbated the COVID-19 pandemic. A report reviewed the major categories of COVID-19 risk factors: poor living conditions and working conditions, air pollution, and poor access to healthcare, and identified the regulatory delays and rollbacks that exacerbated these conditions. I'd now like to introduce David Hayes, who in turn will introduce our keynote speaker, the Honorable Maura Healey, Attorney General of Massachusetts. David directs the State Environmental and Energy Impact Center at NYU, which is co-hosting this conference with us. He is also a professor at NYU Law School and previously served as Deputy Secretary at the Department of the Interior during both the Clinton and Obama administrations. One of my real privileges over the last few years has been to watch from close by the extraordinary work that David has done running the center to support attorneys general in defending and promoting clean energy, climate, and environmental laws and policies, and bring attention to their enormous success in stopping the enormously pernicious policies of the Trump administration. Thanks again to all of you for being here today. I'll now turn things off to David.
Thank you, Ricky. Thank you once again for your always over-the-top graciousness. So I just want to introduce quickly the State Impact Center and get to Maura Healey, our keynoter. So our State Impact Center at NYU is formed in 2017 to support state attorneys general in defending and promoting clean energy, climate, and environmental laws and policies. We are nonpartisan and work with all AGs who advance the cause of climate, energy, and the environment. In that regard, we've worked with the Attorney General community to address climate change in a variety of ways, including supporting state clean energy policies that are leading our country's efforts to transition toward clean, climate-friendly energy. It is in that context in particular that we have seen many state attorneys general draw the direct connection between the climate threat and the health and welfare of their constituents. Attorney General Maura Healey has been a leader in that regard. In May of this year, she released a groundbreaking issue brief that connected the dots between COVID-19's devastating impacts on disadvantaged communities in Massachusetts and the health vulnerabilities that those communities face because of the twin insults of direct climate-driven health impacts like extreme heat and the unhealthy legacy of living adjacent to polluting industrial complexes and highways. Her work inspired our State Impact Center to put on this conference with Ricky and the Institute for Policy Integrity. To further advance the knowledge base of the connections between climate and health, we have just put up on our website a new resource for attorneys general and everyone who is interested in this issue. Here's a shot of our new webpage entitled Climate Change and Public Health. As you can see, we have separate sections on the health effects of climate change, the health effects of burning fossil fuels, which of course cause climate change, environmental justice, and the Trump administration rollbacks. We'll also be posting information about this conference on the website here. So I hope that all of you will use this website as a resource. As you'll see, it's heavy on science, law, and policy, exactly what this conference is all about. Before providing a fuller introduction for our keynote speaker, I want to call out two other individuals who inspired Ricky and me to go forward with this conference. Ricky mentioned both of them. Melissa Hoffer is first, and she's the head of Maura Healey's Environmental and Energy Bureau. She's a skilled lawyer who's passionate about people, health, and the environment. She connected the dots between climate and health before many of the rest of us and has acted on it. She's an inspiration for me and for many in the Attorney General community. And Melissa introduced us to Dr. Stuart Harris, who also deserves a shout out for willing this conference to happen. Stuart has organized and is leading our second panel composed of health experts like him, and I'll give him a proper introduction then. Finally, thanks to the staffs of Policy Integrity and the State Impact Center, particularly Sydney Kalapi, who has worked for months on the content for our climate change and health webpage and has been working tirelessly on the logistics for this event. Now for our keynote speaker. Maura Healey is in her second term as Massachusetts Attorney General, continuing a career spent fighting for justice and equal rights by serving as the people's lawyer. As Attorney General, Maura has focused on confronting the devastating opioid epidemic, reducing gun violence, enforcing civil rights, and protecting consumers. She's also championed access to healthcare and reproductive freedom. But I know Maura best for her work in addressing the climate crisis. She's been a pace setter in the AG community for recognizing the connection between energy and the environment, and more specifically, between the imperative to transition to clean energy and the promotion of human health and environmental health. She's focused simultaneously on enforcing state and federal environmental protection laws, stopping the rollbacks of critically important restrictions on climate pollution, and ensuring that Massachusetts consumers have access to clean, reliable, and affordable energy by advocating for ratepayers in state and federal proceedings. Maura is a graduate of Harvard College, after which she spent 2 years overseas as a starting point guard on a professional basketball team in Europe. She received her JD from Northeastern University School of Law, and it's my honor and privilege to introduce you as the keynoter for this conference.
Well, good morning, David. It's so good to see you. I want to thank you for our partnership and all of the work that you do. The center is really something, and once again, we're pleased to be able to be here today and partner with you. So I want to thank you. I also want to thank, of course, NYU and Professor Ricky Revesz. Thank you so much for bringing us all together and hosting. It'd be nice to be in person, but it's wonderful that we're able to do this virtually, and maybe that enables even more people to tune in. I also note and want to extend a special welcome to my friend Gina McCarthy, who started her career working at the intersection of public health and the environment, and she's just done so much to keep public health at the forefront of her work on environmental and climate protection, and we were proud to claim her as a Massachusetts resident. I'm also really happy to be joined today by Dr. Stuart Harris of our own Mass General, who worked with my team in NYU to organize today's program. Dr. Harris, we're honored to have you here today, and we thank you for your incredible service as an ER physician throughout the peak of the COVID-19 outbreak in Massachusetts. And my deep thanks goes out to all of you, healthcare professionals who have been caring for so many and who have been really dealing up front with the pains of this pandemic. Nearly 200,000 people have died in this country. There are others who've needed your care and comfort under the most grueling of circumstances. And we want to thank you for your courage and your heart and your stamina and your example. I also want to give a particular thanks to my team who contributed to today's event, Maria Hardiman and Pearl Strand on our digital team, who produced the video we'll be sharing with you this morning, Mary Beckman, Chief of our Healthcare Bureau, Christophe Courchain, Chief of our Environmental Protection Division, and most of all, to my colleague Melissa Hoffer, who, as David said, is Chief of our Energy and Environment Bureau and really has taken us forward, not only as an office, but Melissa Hoffer is the leader among leaders when it comes to AG's offices. And I want to thank you, Melissa, for your innovation and for so long now on so many fronts. And this is such a critically important topic. We've seen the importance of this topic in recent months in particular. And I want to thank you for working once again to bring us to this place of really important work and really important effort. You are an outstanding lawyer and a leader, and I am grateful to you for making this possible today. So we've got a great lineup. As I say, we're really so fortunate to be joined in a short bit by Gina McCarthy, and I look forward to hearing from Dr. Stuart Harris. But let me kick this off by presenting a short video that our team put together that talks a little bit about how doctors are directly experiencing how climate change is showing up in their clinical practices and what the implications are for our healthcare professionals and how climate change policy is healthcare policy. So let's tune in.
So I've been thinking about climate change for a while. I think many of us have. And at times it's easy to think of this as something in the distant, out there. At some point, we may have to address it. It is today. It is in my clinic. It is in the hospital where I work. It is in my community where I live.
Hi, my name is Dr. Jay Lemry. I'm an emergency physician and I work at the University of Colorado School of Medicine.
My name is Ashish Jha and I am the Dean of the School of Public Health at Brown University.
I'm Jonathan Patz. I'm a professor and director of the Global Health Institute at the University of Wisconsin in Madison. I first became aware of climate change back during my Master's of Public Health program. I looked into this and I thought, this is a big deal. You know, this is air pollution, population policy, energy policy, and just was an enormous issue that had potential health impacts.
Fossil fuels are dirty fuels and they cause asthma and cardiovascular disease and strokes. Getting off of those fuels and moving towards cleaner energy has these profound effects on our lives that I think we've got to make that transition, not just to run away from something, but towards something else that I think is going to be much, much healthier and better for everybody's health and well-being.
In terms of a patient story that I could share, I work in Colorado and the wildfires in the American West have been prolific this whole summer. And one of the things that we're seeing is patients with pre-existing lung disease, COPD, congestive heart failure, asthma. And when we see our patients and treat them, we write down the cause of their chief complaint. But I don't write down air quality really bad in Colorado. That's so important because there is a cause and effect there.
A couple of summers ago, I took care of a patient, a Vietnam veteran who was hospitalized, basically found at home, confused, unable to take care of himself. We very quickly realized that the two things were happening. One was that he was profoundly dehydrated. Boston was suffering an unusual heat wave, and he was on medicines that complicated his fluid management because of cardiovascular disease that he had. And one of the things that we realized at that moment, the number of heat waves, the number of hot days hitting us in Boston is changing. And it's changing in ways that need for us to change our clinical practice. We have to really think about the medicines we're giving our cardiac patients. patients and think about how they interact in a new climate. When he passed away and talking to his family about his life and his surviving the jungles of Vietnam, and his wife actually brought up the point. She said, after all of that, he succumbed to a heat wave in Boston. And I thought, this is the new reality we're living in. And as clinicians, this is not some theoretical. This is something we have to start taking into account into our clinical practice on a day-to-day basis.
It's impacted me as a caregiver. It's frustrating, right? I know the air quality is being degraded, and I see patients who are very vulnerable physiologically coming in with exacerbations that are directly caused by environmental consequences.
So this is not something that's new. I do believe it is essential for physicians to learn about the principles of climate change and how climate change is going to change clinical practice. And then I think it's essential for physicians to advocate for policies that protect our patients by reducing greenhouse gases and ultimately mitigating the negative effects of climate change.
Climate change is a health issue, and physicians really are the right people to be communicating the importance of climate change because it cuts across so many exposure pathways to affect our health. It's absolutely paramount for doctors and nurses and all health professionals to step up and call out climate change for what it is. It's a health emergency.
I work in a community that's underprivileged. It's a poor socioeconomic community, and we're definitely seeing disparities with people of color and socioeconomic vulnerabilities coming in with shortness of breath, from the poor air quality out here.
Here in Madison, Wisconsin, we have many people that live in poor housing with poor ventilation. It may be in flood-prone areas. We've seen major flooding in the Midwestern United States, and the issue of moldy basements, and we see increases in asthma. So I've seen in this community many people that are affected by climate, and especially from flooding and mold exposure.
So patients have been coming in with shortness of breath, often patients with physiologic vulnerabilities, so pre-existing asthma, congestive heart failure, obstructive pulmonary disease. And when they come in, they're not feeling good. They're short of breath. They can't get a reasonable breath of air. They're speaking in short sentences or even just short word phrases, and they feel miserable. This is something that has really affected people out here.
That I believe climate change is the biggest public health challenge of the 21st century. If we do not tackle it, it will profoundly shape the health of populations locally in Massachusetts and Rhode Island and New York, nationally across the US, and globally across our entire planet.
This should become mainstream in medicine. The effect of climatic extremes, be it from heat waves and worker stress to effects of climate on aeroallergens and ragweed pollen that affects childhood asthma. These are absolutely bread and butter health issues, and climate change should not only be part of the medical school curriculum, but anyone in the healthcare system really needs to step forward and speak to climate change for what it is, a health emergency. Nurses and doctors are the most trusted messengers about climate change. Climate change, it's here, it's now, it's affecting us. It's a health crisis, but it's solvable.
This is not just one of the issues we need to deal with. This is arguably the most pressing public health issue of our times, and we've got to get going on action now.
Okay. Well, hi, everybody. We're so grateful to Dr. Harris, who conducted those interviews, and Drs. Lemery, Patz, and Ja for sharing their remarkable insights and experience. I'm really struck by their stories and the power of their call to face the truth of the moment. Those stories represent the realities of millions of people across our country. Just in the past few weeks, catastrophic climate change events have captured headlines across the country. We can see in real time the horrific human suffering as these disasters unfold. Unforgettable images on TV of twisted grain silos and blasted trees in Cedar Rapids, where a series of violent windstorms toppled millions of acres of corn and soy in our nation's breadbasket. Mile after mile of homes and businesses damaged and destroyed in Hurricane Laura. Homes underwater in Pensacola after Hurricane Sally dumped 2 feet of rain and the eerie orange sky over California from a West Coast fire season so off the charts, the front page of the LA Times headlined it, California's Climate Apocalypse. The public health emergency that is climate change is here. Because fossil fuel companies like ExxonMobil deceived the public about climate change, we lost 40 years we could have spent transitioning to clean energy and avoiding the impacts we see today. But here we are. So we have to reduce our emissions at warp speed while we also adapt to dangerous levels of warming that have already occurred. And that places you, our healthcare professionals, front and center in this moment. Our window to act, we know, is closing, but you and I know there is much we can do to keep this crisis from getting even worse. I think for far too long, if people thought about climate change at all, they thought about polar bears and melting glaciers and charts showing rise in CO2. Now that's all important, but those images have not really helped people to understand the reality and the magnitude of the threat we face. Now, I think healthcare professionals, you all, can change that. Many people still don't understand the links between the health of our families and the climate-driven weather events and related hazards. The sustained drought in California killed over 150 million trees that are now fueling the fires that pollute the air with millions of particles, the air that people are now forced to breathe, air that is so hazardous in some places, it's off the EPA scale. Storms like Hurricane Harvey, which dropped over 1 trillion gallons of rain on Houston in 4 days alone, are made even worse by climate change and leave epidemic mental health crises in their wake. A Rice University survey found that fully half of Houston area residents were struggling with debilitating emotional distress following Hurricane Harvey. And as you heard in the video, more extreme heat waves are claiming the lives of our most vulnerable neighbors and family members. And in so many ways, that's what this moment in our history is about, breaking through the denial and telling the truth about climate change, the truth about the deep structural racism that is still so much a part of the fabric of American life. And the truth about how that plays out, so painfully evident in the communities hit hard by climate change, COVID-19, poverty, and health disparities. Now, many have drawn parallels between the federal government's heartbreaking and lethal mismanagement of COVID-19 and our response to climate change. Critical windows to act were lost because science was denied, and climate change and COVID-19 were deemed hoaxes. We failed to adequately protect ourselves and face the threat head on with the best policies and planning because too many in positions of power refused to listen to the advice of our medical experts and epidemiologists. Just as the increasingly urgent calls of the world's leading climate scientists were for so long also ignored. And COVID-19 is much more deadly, of course, to Black, Brown, Indigenous, and immigrant communities because so many in positions of power and privilege were willing to tolerate the intolerable for way too long, structural racism and the burgeoning wealth gap. And those same disparities have already made the effects of climate change much worse for those communities. As David mentioned, back in May, my office, thanks to the leadership of Melissa and her team, put together a report that detailed the disparate impacts of COVID-19 in Massachusetts. Massachusetts has lost over 9,000 people to COVID-19. We rank 6th nationally for total COVID-19 deaths. Families across our state are still reeling from the devastating impacts of the pandemic, but none have been hit harder than our immigrant Black and Brown and low-income communities, where there's been a public health crisis for decades. Now, COVID-19 exacerbated that crisis. Dr. John Levy of Boston University's School of Public Health analyzed data compiled and collected by our office. And that data showed that communities of color have the highest rates of COVID-19 infection across some of the largest cities in Massachusetts. In April, researchers at Harvard T.H. Chance School of Public Health issued a study linking long-term environmental pollution and COVID-19 death rates. Other factors, of course, play a role. Public transportation may be the only travel option for many people in these communities. Many are essential workers. Living situations may not be conducive to social distancing. There are language barriers, lack of access to health care, and a greater likelihood of having a serious chronic medical condition. These disparities, these social determinants of health, are the predictable endpoint of decades of policy choices that incentivize economic, housing, and environmental injustice. But the way I look at this is that if we created the policies that got us to this point, we can also change them. We can, and we are being called to create something new, and as Dr. Jha said, something much, much better. This is the opportunity we have. We can invest in clean energy jobs to promote economic recovery. You know, in Massachusetts, we employ nearly 100,000 workers in our clean energy economy. Clean energy is good for consumers, the climate, public health, and the economy. We can electrify our transportation and building sectors, prioritize rooftop solar in environmental justice communities, and improve energy efficiency in buildings to reduce pollution and lower costs for families. We have to fight to keep and then strengthen our federal environmental laws that protect health, including clean car standards, limiting methane emissions from the oil and gas industry, and carbon and mercury pollution from coal-fired power plants. We can strengthen requirements to protect our environmental justice communities. We can begin by establishing a better process for regulatory permitting and siting decisions. These things really, really matter, and we need to look harder and work harder on those issues. To do so, that means robust community outreach and participation with project proponents funding community legal representation. If there are 3 words that capture this moment, it's these: I can't breathe. Those were the words George Floyd uttered 20 times as he lay dying with the knee of a Minneapolis police officer on his neck for over 8 minutes. Just one example of police brutality far too frequently targeted at our Black and brown communities. I can't breathe. These are the words we imagine so many of the tens of thousands of Black, Latinx, and Indigenous people in the US spoke as they died of COVID-19 at age-adjusted rates 3 times that of white people. Like the Dominican matriarch in New York City whose son worked at a local grocery store where he wasn't given a mask or gloves, whose daughter took the subway every day to clean one of the city's public hospitals. I can't breathe. And as you just saw, patients struggle for breath in ERs in California, Colorado, Oregon, and Washington, where catastrophic forest fires are choking the air with toxic pollution that's especially threatening to our most vulnerable, people with pre-existing heart and lung ailments like asthma and COPD, many of whom are people of color and immigrants. I can't breathe. What does it mean that so many literally and figuratively can't breathe? That the weight of our intertwined histories of racial injustice and environmental degradation now threatens our ability to live and thrive on this earth. For me, it means we need to be having a very different conversation that recognizes the relationship between health, climate, racial justice, and equity, and approaches problem solving through that lens. Seeing and making those connections so that in this moment of crisis, we lift up the possibility of radical healing. Radical healing of the systems that support racism and violence against Black and brown communities. Radical healing of the health disparities and inequities that force so many to choose between healthcare and medication or paying for rent and purchasing groceries. Radical healing of the systems that put profit before people and the well-being of our environment. You know, as a lawyer, I think I went to law school because I wanted to make the world a better place, to protect and promote the public interest, to try to help people, to protect civil rights. You know, these are the reasons I and many went to law school. And as healthcare professionals, you chose a similar path to protect the most precious gift, the health of human life. Now is our time to build the world we know is possible. There's not a moment to waste. I want to thank you for having me. Again, I want to thank my team in the Attorney General's office for their work on litigations to reports to conferences like today. I want to thank my good friend David Hayes as well, and all of our wonderful participants. We can do this. I really mean it. We can do this. The time is now. We can do this. And I look forward to continuing the conversation today. At this time, I'd like to introduce Lisa Friedman. Lisa has joined us. She'll be the moderator of the first panel discussion, which is strengthening the crosswalk between climate health and environmental policies. Lisa is a reporter on the climate desk for the New York Times, focusing on climate and environmental policy in Washington. Welcome, Lisa.
Thank you so much, Madam Attorney General, and thank you, David, Richard, everyone for having me. I'm so excited to be part of this panel and to be going deeper into a lot of the issues that we just talked about with who I think are some of the smartest people in this field. We have with us today, this morning, a truly outstanding panel. I'll just give the briefest of introductions because you have them all on your sheet. But we have with us Dr. Aaron Bernstein, who constantly reminds me to call him Ari and not Aaron, the interim director for the Center for Climate Health and the Global Environment at Harvard T.H. Chan School of Public Health. Dr. John Holdren, former science advisor to President Barack Obama, and the Teresa and John Hines Professor of Environmental Policy at Harvard Kennedy School of Government. Gina McCarthy, the former administrator of the EPA under President Obama and the president and chief executive officer of NRDC. And Dr. Sudeep Parikh, the chief executive officer and the executive publisher of the American Association for the Advancement of Science. Welcome, all of you, and thank you so much for joining us today. Is everybody online? Okay, I'm gonna keep going. We're going to cover a lot of ground in the next hour. We're going to talk about the links between climate and health, how we communicate it, what we're doing or not doing right now on a federal level, what policymakers can be doing locally, and what stands in the way of action, and how we can work around that. I thought that video, Maura, that you showed was really just astounding. And I was going to open, Dr. Holdren, with you, asking you to describe the range of ways that we know how climate change is affecting health. But given that terrific video, maybe I can ask you to zero in on some of the major intersections of climate and health where you think the federal government should be really focusing its attention right now. Uh-oh. Are we?
John, I'm sorry, you're muted.
I thought somebody has to unmute. Okay, there we go. I had been muted by the host. Can you hear me now? Okay. So thank you very much, Lisa. Let me do my best with a big charge. Until about a decade ago, most scientists thought that the biggest direct impacts of climate change on human health were going to be, first, the spread into higher latitudes of tropical and subtropical diseases, things like malaria, dengue, cholera, West Nile virus, and so on. And secondly, deaths in heat waves, particularly among the elderly trapped in the world cities. Also on the list of health impacts that were expected to grow under climate change were deaths and injuries from hurricanes and typhoons of increasing power and from more widespread flooding caused by the torrential downpours that are associated with the higher water content of a warmer atmosphere. Also frequently mentioned were diseases from pathogens and toxins unleashed by coastal and inland flooding, increases in deaths and illnesses from air pollution made worse by changing atmospheric conditions, and worsened allergies because of climate-driven increases in pollen. Today we understand, I think even more clearly than before, that all of these climate-linked health impacts are important, and some of them have been growing even more rapidly than we feared before. But two other impacts on human health have risen even faster in scientists' estimation of the harm from climate change. The first one is heat stress and heat stroke from increased heat and humidity outdoors. We now know that the combination of heat and humidity in the warmer parts of the world has already reached levels in the warmest months of the year that make it impossible to work outside or even be outside without risking heat stroke. And the areas and durations over which this is happening are expanding frighteningly. The second of these recently upgraded hazards in our estimation is health damage from smoke pollution from the wildfires that climate change has made much bigger and more powerful in many parts of the world. In the last few weeks, most of us have already seen in the media that the fine particulate pollution in major parts of the American West, driven by huge wildfires, has been worse than the notorious particulate pollution in Delhi and Beijing. Other impacts of climate change on public health that have the potential to become catastrophic include malnutrition resulting from declining productivity of agriculture and marine fisheries in many parts of the world, and diseases spreading among densely populated and unsanitary camps housing climate change refugees who have fled their home regions after climate change made these unlivable. If there's any silver lining in all of this, it's that increased public understanding about ongoing as well as potential damages to their health by climate change is lifting up the political salience of the climate issue, and so increasing the chances that society will take the actions that are needed to address it. Thanks.
Thank you, John. Dr. Bernstein, let's focus on COVID-19 for a moment. Your team has really been at the forefront of some of the groundbreaking work linking COVID-19 vulnerability to death from COVID-19 with long-term exposure to air pollution. Could you tell us a little bit about that study specifically and what we've learned since then?
Sure, Lisa, and I just want to acknowledge how grateful I am to be able to share the session with you and John and Parikh and Gina, and for Stuart for reaching out to me, and to Attorney General Healey and Melissa, whom I've worked with in their tireless efforts on these issues in our home state of Massachusetts. You should all know I'm actually a practicing pediatrician. In fact, most people would identify me that first before my affiliation with our center at Harvard. And I think the issue you raised, Lisa, around air pollution and coronavirus is one that colleagues of mine at the School of Public Health really dove into very quickly. I was not directly involved in the research you cited, but I do know the investigators pretty well. These are folks who have spent their careers trying to understand the effects of air pollution on health. The study was led by Xiao Wu and Rachel Nethery, and the senior author is Francesca Dominici, and they looked at air pollution over the span of a decade or more in counties across the United States, and found that in places where there had been more air pollution, very small increases on the order of 1 microgram per meters cubed, So as you heard about from John and others, the air pollution in the West right now, the levels of particulate matter in the air could be 80, some cases over 100 micrograms per meter cubed. So a long-term change in 1 microgram per meter cubed was associated with an 8% increased risk of dying from coronavirus. Now, the authors would be the first people to tell you that their study alone is not evidence enough to rush to a conclusion about the effects of air pollution on dying from the disease. But then, of course, we now have over a dozen other studies that have found similar findings, including a study that was published just last week, again in the United States. And these are studies around the world. They have different methods, they use different study designs. And many of these studies are not the best sorts of studies to prove causation, but we also know that air pollution causes diseases, very definitively causes diseases like heart attacks and strokes and other medical conditions that are strongly associated with people dying of coronavirus. So whether you look at it from the direct effect of air pollution on the risk of dying from the disease or its effects through causing other diseases, there's a strong risk. And has already been mentioned, this is a huge problem because it strikes the people who have been historically left behind. The air pollution in the United States disproportionately affects people of color. And it's not just that Blacks and Latinx communities are exposed to, in some studies, 20, maybe 60% more air pollution. They produce less. They're responsible for less. Their behaviors in our society actually consume less goods and services and energy, so they're producing the least and exposed to the most. And then, of course, we hear the data that Attorney General Healey referenced about the outstanding and horrifically outstanding higher mortality rates in, for example, the Black community in the United States, 2 to 3 times higher. And we're left to wonder, are we looking at the long tail of redlining in the United States with some of these COVID outcomes? And I think it's critical to recognize also that the pollution that we're talking about is driven by fossil fuels, particularly in cities from transportation, increasingly so. And as my colleague and friend Ashish Jha mentioned in his remarks, we know that we can take actions to get off of fossil fuels and not only reduce the rates of diseases like heart attacks and strokes, we may in fact reduce severity of disease with coronavirus, and we can take anti-racist actions. And so it's, we've tried to connect these dots between climate action, pandemic actions, and equity actions, that these solutions, in fact, get at all of those with the same activities.
Thank you. I've been told there was a little bit of a funny noise when I was speaking. I took out my earbuds. I hope this has helped it for the crowd. I'm going to circle back to those equity issues with Administrator McCarthy in a moment, and I really want to go deep into that. But first, before that, Dr. Park, just sticking with this science around COVID-19 and exposure to air pollution. I mean, this study was attacked immediately by the Trump administration, EPA, by the initial study, by Republicans in Congress. I'd like you as a nonpartisan science organization that has been working with both sides of the aisle on science issues to talk about your experience with the growing partisanship around science in the case of this instance, COVID and air pollution, climate change, and how this affects the ability of groups like yours to work towards solutions.
Thank you, Lisa, and thank you everyone for the invitation to speak on these issues. These are really challenging times to be a nonpartisan, thoughtful purveyor of scientific information, and that's the first thing I'll say. AAAS is 170 years old. Throughout that time, we've really worked to try and build trust with parts of the society that are outside of science. So we have programs that put scientists in congressional offices, scientists in newsrooms around the country. We have programs where scientists meet with members of the faith community. We have programs where we talk about climate change with judges. And that's all been happening for decades. And we have relationships that are built and that are strong on both sides of the aisle. The challenge in this moment is that those are under incredible strain. So the moment that we never sacrifice credibility or truth or facts to keep those relationships. And so we speak the truth. And so when we say that that climate change has health effects, climate change has human origins, we do face blowback, and we face it's rare that as AAAS we get called a leftist organization. That's happened in the last couple of years, and that's a really it's a strange place for us to be as an organization. That said, we continue to play the short and long game. We continue to have relationships, and the thing that a lot of the folks on this video conference know is that Washington has many, many layers of relationships and interactions ongoing all the time. And while there's this white hot heat of the political moment, there's continuing conversation on both sides of the aisle about science. Even in this, during this last 4 years, the funding for science has increased quite a bit for many agencies, not the EPA. We can talk about that. But there is support for science across the spectrum. We just have to find ways to work together. And I can talk about some of those ways later on, Lisa, but it is very much a challenge right now.
That's a great opening. And you and I have talked about some of the ways that you're working with local communities to get around some of the white hot debate in Washington. And I definitely want to come back to that. But I want to turn now to Administrator McCarthy. I would love for you to go deeper into this issue of environmental justice. Walk us through why and how Black and Brown communities, frontline communities, are more vulnerable to illnesses related to air pollution and climate change, and what are the things that we need to do to address it at a systemic level? I'm reading that Gina is not able to get her video started. Oh dear. Okay. Well, let me turn that question for now to you, Dr. Holdren, and hopefully Administrator McCarthy can join us in just a moment. Dr. Holdren, can you talk us through some of the ways that we can start to address this systemic racism that is embedded into the system of how and where we build industrial hazards and polluting industries?
Well, as a start, we have to recognize the problem, and that is now finally happening. I mean, I have been aware for many decades of very capable people working on the issue of environmental justice and pointing out the extent to which communities of color, various ethnic communities, folks who have already been pointed out, produce much less of the problem but bear a higher share of the impact. But only really recently has this understanding, I think, started to pervade the society more widely. The understanding that poor people, that Black people, that Hispanics, that Native Americans are all subject to far more than their share of the pollution generated by fossil fuels, and indeed a variety of other pollutants, and that the only way to fix this is to address the fundamental problems of racism and injustice in the society, including by taking much greater measures to lift these groups out of poverty, to lift them out of the discrimination that they have suffered. And at the same time, we can't forget that even the best off people in our societies are vulnerable increasingly to the impacts of climate change, that everybody's going to be affected, and that therefore an important part of the solution has to be addressing the climate change issue head on and addressing the panoply of other pollution issues head on. In respect to climate change, the United States needs to start by rejoining the Paris Agreement. The Paris Agreement, of course, was only a first step toward what needs to be done, but it was a big first step. It was an important first step. And of course, President Trump, very shortly after he became president, announced that the United States would withdraw. That doesn't formally happen until early November, but he terminated immediately essentially all of the steps that the United States was taking to comply with the commitments it made in Paris. We've got to reverse that. And pretty obviously, the only way to reverse it is going to be by electing a new president, electing Joe Biden. And at the same time, I believe that the new president I'm hoping for, a President Joe Biden, will take a range of other steps needed to address the specific problems of racism and inequity in the way people are exposed to the hazards of climate change that are being discussed here.
Thank you, Dr. Holdren. Just wondering, is it possible, I don't know, Administrator McCarthy, if you can hear or if you're able to join by audio, even if the video is not working? Okay, I think unfortunately for us, we are not going to have her on with us. Hopefully something will change in the next little bit, but for now, let's continue. You know, so this is for either Dr. Parikh or Dr. Bernstein, you know, whomever, you know, would like to take this. Can you walk us through, I mean, if the federal government rejects science that shows the link between air pollution, climate change, and illnesses or premature death, who is helped by that? Who is protected and how? And, you know, is it plausible at this point that we don't know enough about these links to take action, which is what, you know, this EPA has been suggesting? You know, so sort of a two-pronged question. I mean, walk us through how this protects, I assume, industry by not recognizing these scientific links, and what, you know, whether it is accurate or not that we really need more information before we move forward with tightening regulations on air pollution. Maybe if I could ask Dr. Bernstein to.
Sure. Well, if I had to channel my inner Gina McCarthy, since she's not here, but she can yell at me later if she doesn't like it. You know, one of the lines she likes to use is, you know, this current EPA has shown a great affection for protecting the polluters, but not for protecting people. Oh, there she is. She popped in for a second.
Oh, do we have her?
Gina, I was just quoting you since you weren't able to join, but since you're here now, I think we can let you chime in. Gina, I was just channeling your thoughts on the question that Lisa had asked, and I don't know, Lisa, if you want to re-ask it about.
Yeah, I'm happy to repeat the question. Thank you for joining us, Administrator McCarthy. We're so happy to have you.
I am so sorry I got a little bit delayed here. I couldn't get the camera to work, so it must be my lovely face.
We are all doing our best with work from home and Zoom technology. Be prepared to hear my puppy bark any minute now, friends. Administrator, I was asking if you could, you know, what I'd love for you to do is sort of walk us through who the winners are if, you know, the federal government rejects studies, as it's doing, that shows the link between air pollution and illness and premature death, or climate change and health. We've talked a lot about who is hurt, but who is helped here? Who is it that's protected? And as a related question, I was asking, is it plausible at this point that, as the CPA has argued, we don't know enough about these links to take greater action?
Well, it's it's a bit shocking to me that anyone could still have the view that we don't know enough, because the data has been clear for years. You know, one of the most interesting things that I found during the COVID-19 epidemic was everybody's surprise when they found out that, you know, that Black people were much more severely impacted when they were exposed to COVID-19, dying at a 2-to-1 average when compared to white people. And you know, we've known that in the environmental community forever. That's why we talk about frontline and fence line communities. And so the only benefit that I can see to denying science are to people that like things as they are. In this case, it would be the fossil fuel industry understands that if you can deny the science long enough, then you can delay actions that may disbenefit them in terms of their view of what keeps their corporations functioning. So to me, what you're seeing happening now at the federal level is an administration that cares more about polluters than people. You know, they are clearly protecting what they consider to be their base and shifting how the government would normally look at science, would normally respond to it, and would normally make policy shifts, not complete abdication of their role and responsibility. And they've just chosen to make sure that they send the right signals to polluting industries that they shouldn't have to change. And science is a fundamental way of ensuring that change does happen as we learn more. So we don't win. And frankly, the people in corporations don't win, but those who intend to make money out of it, as opposed to protect people, do win, at least in the short term. But when it comes to climate, you know, it's one planet. We're here to protect the planet because we care about the people. So they don't win in the long run if they want to have a healthy life or if they want to hand their children a future to be proud of.
And since I know we have to lose you a little early, I'm going to keep you on deck for another moment if I could. One of the most controversial pieces of regulation that is still being finalized, we should be seeing it, you know, maybe this month, is a regulation that the EPA calls the Strengthening Transparency in Science, in Regulatory Science. You know, folks in the science community have called it the secret science regulation, with air quotes around secret science. Administrator McCarthy, so I mean, the short version of this, I'll explain to viewers. The administration would like to discount studies in which the raw data is not provided when it chooses what studies to use to make or strengthen regulations. Administrator McCarthy, can you talk about this regulation and why you find it so problematic and why so many people in the scientific community do?
Yeah, you know, it's really funny, Lisa. This was one of those rules that I think they thought they could easily get through because it's been lingering for a while. And I think they thought that because they basically kicked out a lot of the scientists off the Science Advisory Board that could provide real scientific advice. And they put a lot of industry representatives that were scientists on the committees, thinking that this would be an easy thing to just keep rolling through the dismantling of all these rules. And in fact, they found that even their hand-stacked Science Advisory Board was saying, hey, now wait a minute, this is really going too far. Because basically, as you indicate, you know, what it does is it's not about transparency. Transparency is great. Data sharing is wonderful. But they're just defining it in a way that doesn't allow real science to be considered. That is their only purpose in doing this, is to dismantle, and Ari can speak to this more, one of the fundamental and premier scientific work that was done to show that pollution in the air causes really direct and severe health benefits, which we now know more and more about, was called the Six Cities Study. And it was really a longitudinal study over a massive amount of individuals that gathered enough data, and this has been something they've been yapping about for a long time, the folks who don't want this to continue, that gathered a lot of data that really proved that air pollution causes really serious health consequences. And that was used as an underpinning for the Clean Air Act to regulate all kinds of sources to reduce those emissions that cause that damage. And it allowed us to basically value and calculate the benefits of those reductions in a way that allowed us to have very cost-effective ways of pushing the utility industry to get cleaner and cleaner. And what they're trying to do with this rule is to rule out that study because it would reveal, it would continue to allow us to regulate. But the problem is that revealing that data would require us to reveal data at levels that would personally reveal data that mattered to human beings, individual. That would be precluded from being publicized and given to the public. And this has been going around, Lisa, for 10 years. This came up first, maybe 15 years ago. And the EPA actually paid $3 million to hire 30 million scientists, really great people from the Health Effects Institute, to relook at all of the raw data and to independently evaluate it. And they came up with essentially the exact same scientific opinion about the relationship between air pollution and health impacts. But apparently that wasn't good enough. We're supposed to hand to everybody public information about people's medical, history as a way to somehow bring more transparency, which we all know is ludicrous. It'd just be a food fight to all those who want to misinterpret it and to wreak havoc instead of leaving it in the hands of scientists who have access to all that raw data if they want to ask for it and will use it in a proper way. So it's not precluding transparency in way, shape, or form. It's clouding clear science, and it's taking away our ability to rely on good science to make decisions that are essential for protecting public health and the environment.
Thank you.
Other than that, it's a terrific idea,
Well, I mean, so just turning for a moment, Dr. Parikh, to you. I mean, a number of the studies that Administrator McCarthy referred to, epidemiological studies, longitudinal studies of the effects of exposure to people over time. Can you, a lot of the studies that are really being targeted here, not just in relation to, I know we're here to talk about the link between climate and health, but also pesticides and chemicals are also, I think under fire in this administration. A lot of the studies that they're targeting are epidemiological studies, recognizing that much of the audience are public health professionals, but for those of us who aren't, can you explain why epidemiological studies have come in the crosshairs of industry and conservatives when it comes to regulating both air quality, chemicals, pesticides?
Well, they're powerful data. They're compelling. Epidemiological data tells you what health effects there might be in a large population, and it shouldn't be about the individual. And so as AAAS rarely takes such definitive stands on issues like this, but this was one where it was so clear what would happen without access to this data, without access to these studies in the performance of making regulation, that it was clear for our board that we had to speak out directly and call a spade, which is to say it's almost Orwellian to call it transparency. It's the opposite of that. And so, the epidemiological data that really would inform not just the current regulations that are there, but frankly, as you look forward, there's more and more of this data that will be coming to us. We have we have wonderful studies that are ongoing at the NIH and in the VA that hopefully can also provide more data that can be valuable for making regulatory decisions. And this is a prelude to that. And so at AAAS, we view it as this is not putting data and science at the decision-making table. And that's what we're about. We have to have data and science at the decision-making table. And when it's there, then we can have an argument about it. But let's make sure it's there first. Let's not take away the data and then try and have an argument without it.
Thank you. Dr. Holdren, we're seeing dismissal of science in a lot of areas. You've recently, the National Academy of Sciences, more than 1,000 scientists called on policymakers to restore evidence-based science making, especially when it comes to challenges like the global pandemic, like climate change. What areas worry you most right now as you look at the administration and how it is using or not using science?
Well, let me say a couple things. I first want to make one addition to what Gina McCarthy already said, and that is in the conduct of these studies, like the 6 cities study that she mentioned, binding agreements were made by the investigators with the individuals whose medical records were used. And to release the raw data containing individual medical records to the public would violate those agreements. And this is part of the whole preposterous character of this transparency proposition that the advocates of clouding this issue have put forward, that it would in fact violate the agreements under which the studies were done to make public the individual information that became part of them. In terms of what worries me most, I have to say that the overarching issue has been the replacement of people at and near the top of our departments and agencies with science and technology responsibilities with people who are basically anti-science, who are deniers of the realities that science has brought forward. And the result of that substitution, along with the dismantling of many of the key advisory committees, has simply cut science off from the decision-making process in these agencies. It's happened at the EPA, it's happened at the Department of Interior, it's happened in the Department of State, and there's now reason to worry that it could even happen in NOAA. It's happened in such a pervasive way that when people ask me what is the first thing we need to do to restore integrity and the applicability of science and technology information in government, is we need a house cleaning. We need a president who will appoint people with real expertise, with relevant experience, with commitment to the public good to these positions. And what worries me above all is the further damage that will be done if we have another 4 years of know-nothings running some of our most important science and technology agencies.
Thank you. I want to take this opportunity to tell the audience I'll be happily taking questions from the audience in a bit. If you would like to use the Q&A to type your questions, I'll be taking a look in there. Dr. Perry, tell me, just some of the partisanship and the rejection of science that Dr. Holdren was just talking about has led you to start increasing your focus at AAAS on state and local governments. Is that an accurate? Tell us a little bit about the work, about why you're shifting to working with local governments and what you're doing.
Sure. We continue to work at the national level, so that doesn't stop. It's incredibly important. But what we found is that while these hot debates are happening in Washington, we can have more of an effect by building that trust and building those relationships at the local level, where there may be either more openness because the the political leaders are open to science, or more open to science, or because there is such a challenge, such an acute challenge, that people are willing to work together, even if they don't necessarily agree on the root cause. So I've talked a bit about some of the work that AAAS has done in terms of communication on issues of climate change. The first was, what do we know? What do we know as scientists, and trying to put as much fact into place as possible. And then how do we respond? In that How Do We Respond campaign, we worked with people at the local level who did not believe that climate change was causing the particular local acute problem they were facing. The lack of fish in their streams, the change in water temperature in their lakes. But they realized that scientists were part of the solution to these problems. And so we're able to build those relationships of trust that hopefully over the course of years can build more and more over time, so that that trust leads to eventually trusting us on the bigger issue as well. It's a long game, and we want to make progress. And so we do this, we want to make sure that we take advantage of that relationship now and in the future. It's not a replacement for change at the national level. It is a Band-Aid. It's working to change some hearts and minds at the local level, but it's definitely not a solution at the global level.
I think that's a really key point too. Yeah, you're right. And just going back to the transparency rule, one point that Gina raised to me in a note just now, and I think this, maybe she or Dr. Bernstein can speak to this. I mean, if are other agencies, what would happen if other agencies, the FDA, the NIH, were asked to employ the same level of transparency, provide the raw data, the medical history, the medical information of all the respondents in a study before they move forward? I guess there's a couple parts to that question. Is that something that could happen, or are those agencies operating in a different way, and that wouldn't be a factor? But what would the conclusion be there? Would that not allow us to create vaccines or other protections?
Lisa, I'm thinking on the fly here, so I will look to fellow panelists as well. But NIH, not being a regulatory agency, it's a slightly different animal in that at the research level, there is sharing of data. But again, all the rules of privacy, all the rules of human subject protections are in place at NIH. And again, you're not making regulatory decisions at the NIH. For the FDA, you're looking at a different set of data that does not include individuals that the FDA is looking at. And I don't, look to my fellow panelists, but they're not looking at individual data for making decisions on clinical trials. They're looking at the data that comes to them from the DSMB and the other panels that look at this first on the outside. So again, I think that would be really, really horrible if the FDA were having to look at individual records of individual patients. But again, I'll turn to my fellow panelists as well.
Dr. Bernstein, Administrator McCarthy, any additional thoughts on this?
I guess, Lisa, the point I was making is if it's required to have this level of transparency for science to be considered by a federal agency, why is EPA the only one that has that requirement? And if you step back and say to yourself, okay, do you think chemical manufacturers who want their new products to be brought to market would be willing to live with that same scrutiny? What about people who get tested for new cancer treatments? Do they really want their work to figure out that they have cancer? Do you know what I mean? There are many layers of this. And it's funny how people think some kind of regulatory agency should be held to a different level of scrutiny on what sound science is than scientists in the federal government are held to. So I do think there's ramifications here that made EPA pause and think, should we really rush to this judgment in our effort to try to undermine regulatory decisions and our ability to make these connections that are central to good regulation? Are we really going to undermine way more than that? And I think given that EPA regulates chemicals that industry brings to market, or whether they bring them to market, it's a slippery slope that they have to worry about by talking about this as if this is the distinction between good and bad science.
I think I'm going to use this opportunity to segue and keep you for a moment, if I could, on co-benefits. You know, co-benefits is also something that this administration has taken aim at. Explain to us how the EPA under the Obama administration, under your administration, thought about co-benefits from climate regulations and what the changes that EPA is proposing now would mean for public health.
Well, Lisa, very simply, we thought about co-benefits the exact same way that Ronald Reagan and every administration since Ronald Reagan's administration has thought about it, which is you don't ignore the full benefits of any regulation, nor do you ignore the costs of those regulations. And so for some reason, this administration is fully prepared to look at all the costs of a regulation, but they've decided that benefits like, and in particular, where this is most acute right now, is re-regulated mercury emissions from the utility sector. And the utility sector themselves did not want that rule to be relooked at because it already sunk billions of dollars into the equipment that was necessary to get mercury pollution out of the air, because mercury pollution is a neurotoxin that makes its way into our food system through fish, and it impacts, severe impacts on kids and fetuses. So in order to undo that rule, which the administration was still intent, even though the major utility lobbyists said don't touch it, in writing said don't touch it, they decided to go after it. And the only way that they could go after it was to actually eliminate benefits beyond mercury that the equipment themselves basically address. You cannot get mercury out of the air without also taking particulate matter. It's impossible. And so you always calculate that in a cost benefit because the co-benefits of putting that equipment on are gigantic. And why would you not look at co-benefits when you look at every co-cost? And so this has been a rule in the federal government for a very long time as an executive order and as rulemaking that govern Office of Management and Budget. And this administration just decided if I don't have to worry about those pesky benefits, it's really hard to put a cost on losing IQ points for our kids and calculating the mercury benefits directly. And so they decided to get rid of it in hopes that it would look like a more reasonable thing to do, when it really doesn't anyways. But they're trying to make that a new way of doing business, which is let's make sure we look at every benefit we can ever think of from a cost perspective, but let's make sure we minimize the kind of benefits we want to look at from a health perspective in the most ridiculous ways imaginable.
Thank you.
Could I just add, Lisa, could I just add that this stance, this attitude really starts at the top and pervades the system downward from the top through the people that the president puts in place in the departments and agencies. The reason we had the opposite in the Obama administration is that President Obama himself understood how and why science and technology matter to virtually every dimension of the national agenda, whether it's the economy, healthcare, climate change, the rest of environment, national security. Science and technology matter. When you have somebody at the top who rejects the basic proposition that science and technology matter and puts in its place the proposition that advancing the financial interests of the rich donors to that administration is the top priority, you got a problem. And again, it pervades the administration from the top down, and that's why we need a different administration.
Well, we're certainly going to get to, sort of policies forward looking in a moment, but just sticking with the idea of co-benefits, the other side of this is a communications aspect, how we talk about the benefits of reducing fossil fuel emissions, the benefits of reducing pollution. Dr. Bernstein, when you and I chatted last week, you described some of your concerns with describing the benefits that come from climate regulations that address traditional pollutants as co-benefits. Explain to me where, and that was a communication issue for you. Tell me a little bit about how you would like to see policymakers communicate climate and health in a new way.
Thanks for that question, Lisa. So I've been thinking about climate change and health for about 20 years. And I've watched, and John Holdren mentioned this, 20 years ago, there was almost no one anywhere thinking about climate change and health systematically. You heard from Jonathan Pass. Jonathan is one of the really early folks engaged in this. But people were talking about polar bears, as Gina likes to talk about. They're talking about sea level rise. And then, at some point, right around, the early aughts, co-benefits was defined as a term. And in my view, that's putting the cart before the horse. When I am seeing a kid who can't breathe, Attorney General Healey talked about this issue of not being able to breathe. I've seen more children not able to breathe in my lifetime than I would like to ever see in anyone else's. The mother does not care about climate change. She couldn't give a hoot about what's going to happen to the planet in 50 years. She wants to know if her child's going to suffocate in front of me. And so when we talk about co-benefits, we're missing the boat. We're putting the cart before the horse. These aren't the co-benefits, these are the benefits. This is what people, everyday people, the people who we need to get on board to take climate action care about. And by calling them co-benefits, we suggest they're simply unimportant. The real problem is climate change. Now, I'd be the first to say that climate change is a huge health problem. You heard it's not just a health problem in general, it's a health problem for health care and people like me to do our jobs. I have colleagues in California right now, you'll hear from one of them this afternoon, Kari Nadeau, who are dealing with the wildfire smoke. There is nothing we can do for children really to protect them from wildfire smoke. That's the honest truth. We can keep them indoors, but for the children who are most vulnerable, the HEPA filters aren't available, and even if they were, they might not protect them. So we need to start talking real seriously about how we talk about health benefits and climate change. And we need to think real hard about whether people are going to care about co-benefits or whether they're going to care about their child able to breathe from the pollution that's generated by burning fossil fuels. And more importantly, we need to focus on the reality that 1 in 5 children in this country have asthma. These are children who wouldn't have had asthma. The best science we have, this comes out of Susan Annenberg's work at George Washington and others. The fossil fuel pollution in the United States is causing children to have asthma who wouldn't have had it. It's causing children to be born too early and too low birth weight. That means their lungs aren't going to develop well. And you know what that means? That means when they grow up, if heaven forbid we have another COVID pandemic, they're going to be more likely to die. Because we know that children who have impaired lung development are more likely to have chronic lung diseases in adults, and those people with COPD are more likely to have severe respiratory outcomes. So I think we need to think about the benefits we stand to gain through reducing air pollution, particularly for the most vulnerable, and talk about those as the benefits of climate action, because that's where people's minds are at.
So what does that mean from a, do we rhetorically then discuss climate change as the co-benefit, or is there a new way of of communicating this that you, maybe Administrator McCarthy, others have been chewing on?
I think, Lisa, if I might, I think it's actually pretty easy. You know, being a clinician, you learn pretty quickly, and smoking is a great example. I could talk till I'm blue in the face to someone, an adolescent, who started smoking, telling, you know, in 30 years, you're going to die from lung cancer. You know how well that works to an adolescent who's smoking? It's like asking them to smoke, more or less. It's almost encouraging them. You have to start, if you have someone who doesn't see the world as I do, which is I know that child is at great risk of having lifetime health effects, but that's not where their mind at. You have to meet them where they're at. So to folks in the United States and around the world who understandably, especially right now with a pandemic, with an economic recession, we have to understand where their concerns are. Now, the good news is that pretty much any climate action we can take is going to benefit their health right now. There are things we should be doing anyway. The diets, the reliance on single, user cars, all these things we need to change because we have an obesity epidemic that is decreasing in, lifespans of children in the United States. And so if we say these are benefits for your health, and they say, you know what, there's another benefit. And oh, by the way, you're going to provide for a livable, more just future for your children. It's not about benefits and co-benefits. Co-benefits is a technical word that, in my view, tends to make the folks of people I care for, their eyes glaze over. We need to talk about the benefits of health actions, and we need to talk about providing for a future that we would want to give to our children, the future they deserve. So we don't have to talk about benefits and co-benefits. We can talk about benefits now that promote equity, that help children lead their fullest, most healthy lives possible, and provide for a future that we would want.
Super. I know we only have Administrator McCarthy for about 3 more minutes. So Administrator, there's a question that came through via email that I'd like to put to you. Is there any thought and to pursuing a regulatory policy or strategy that achieves far more public health protection than we currently have through an ambitious yet feasible secondary, this is going to be an in the weeds question.
Yeah, it is. I see it. Yeah, it's weedy.
For greenhouse gases under the Clean Air Act. Essentially the questioner is asking, a way to protect public health broadly from dangerous levels of climate change.
Yes, is the easy answer. There's lots of ways in which you could look at utilizing the Clean Air Act to try to reduce carbon pollution, which the Supreme Court and Ruth Bader Ginsburg, I thank her for being in the majority on this, helped us get through to understand that we have to regulate pollution that kills us, and carbon pollution is such a pollutant. We have looked at it, but in all honesty, Lisa, I've looked at it a lot and it keeps continuing to linger. That process is lengthy. It is time consuming. And frankly, the longer we delay taking action, the more difficult this issue becomes. So I think that is one of the most complex ways of dealing with it. Instead of going sector by sector to look at how you would set standards that are protective of health, and address climate change, as Ari said, you can get lots of twofers and threefers here, because anything you do to reduce air pollution is going to also take some of the sting out of fossil fuels and will head us in the right direction. But it's also investing in new technologies. One of the most exciting things is that when you start thinking about it, we need to boost the economy. If every penny we had to get us out of our economic doldrums that we are in because of this pandemic was spent on clean energy, you would get great climate benefits, you would restore the health of populations, and you would set our children off with a bright future. If we can just think a little bit firmer about what we want and demand it and spend money that way, bingo. We have hit that touchdown. So you can talk all wonky you want, but if it takes longer than 3, 4, 5, 10 years, I ain't got the time, and neither do any of us. So we got to go and hit the ground running right away.
It was such a pleasure to have you with us. Thank you so much, Administrator. And
thanks, team.
I'm going to, in our last 5 minutes on this panel, I would like to bounce off of the administrators' forward-looking optimism and ask each of you, we don't know what November is going to bring, but if there was a single policy or regulation that would really most address this nexus of climate and health, where is it that you would concentrate? Can we start with Dr. Parikh?
From the AAAS's point of view, it's really about getting science at the table. So the transparency rule should not go into place. Is probably the very first thing, because that creates a logjam with a whole bunch of things behind it. So if you're asking for one thing, I would say that not happen.
It'll be in the courts, like a lot of the regulations that are coming out. Dr. Bernstein, what would be your number one policy focus?
Well, I think it's a price on carbon. I think we can talk about the best way to make that happen. I'm encouraged by the states that are taking action now, and there are obviously pros and cons of various ways of doing that. But I also want to make another more specific recommendation, and it really speaks to the moment, which is colleagues of mine in the Gulf Coast and California talk about how there are very few people who have been trained and prepared to deal with the health consequences of these events. I heard from Jay Lemery in Maura Healey's video. Jay's a friend, colleague, known him for a long time. And Jay is one of 2 people running fellowships. There are only 2 fellowships in the country that deal with climate change in medical practice. One is there, one is at the Beth Israel in Boston. We need to ask NIH to step up. We have essentially 0 funding from NIH to train people to do research. It is appalling to me, frankly, that we have everyone here saying climate change is a huge health problem facing the United States. And by the best estimate of the entire NIH budget, a generous 0.05% is focused on climate change and health. How are we going to train people? How are we going to do the research? How are we going to get people in public offices, both at the state, national, municipal level, to be able to respond, let alone prevent the threat of climate change if we do not invest in it? And I think it would be an important action of a new administration to set an executive order to direct NIH to focus on climate change more squarely in its grant making.
That's really interesting. Thank you. Dr. Holdren, close us out. Where would you put your policy focus on climate and health?
Number one, restore respect for science at the top in both the White House and across the agencies. Number two, build partnerships across levels of government, across the public sector, the private sector, the academic sector, the civil society sector, to innovate more rapidly in the domains of cleaner energy technologies. Number three, do the same for investments in adaptation to the changes in climate that we can no longer avoid. Adaptation has been the poor stepsister of investments in emissions reduction. It is equally important because no matter what we do in emissions reductions, we cannot stop the growth of emissions and the changes in climate overnight. We have to fight it at both ends, both mitigation and adaptation. Those adaptation steps can do a lot for us in the public health domain, as well as in other aspects of climate change.
Wonderful. Really, the three of you left, I cannot thank you enough for your time and your excellent insights today. I want to tell the attendees there will be a short break now between this and the second panel, a 15-minute break, and the conference will pick back up again at 12 p.m. with the second panel discussion on climate-related health issues. Dr. Holdren, Dr. Bernstein, Dr. Parikh, thank you all so much for a wonderful discussion this morning.
Thank you.
Welcome back, everybody, for our very interesting second panel. I'm going to introduce, I'm David Hayes, by the way, from the State Impact Center at NYU. Thank you again for being a terrific audience this morning. I'm going to introduce Dr. Stuart Harris, who will introduce his panel and kick off a fascinating discussion with health experts about climate impacts. Stuart is the founder and chief of the Massachusetts General Hospital Division of Wilderness Medicine and the director of Mass General's Wilderness Medicine Fellowship. He is a full-time attending physician in the emergency department and an associate professor of emergency medicine at Harvard Medical School. He graduated from the Harvard-affiliated emergency medicine residency in 2003. Stuart's research is fascinating. It focuses on investigating the pathogenesis and treatment of high-altitude illness and on the interplay between climate change and human health. He's been conducting research with the Himalayan Rescue Association in the Mount Everest region since 1999 and the U.S. Army's Research Institute for Environmental Medicine since 2004. One of my favorites on his long resume is that he worked at a Denali National Park Climbing Ranger Patrol, where he performed the first ultrasound imaging on the summit of North America. He's a co-creator and faculty on the month-long medical student course, Medicine in the Wild with Knowles. That's the National Outdoors Leadership School. That's focused for more than 15 years on introducing young medical students to the risks and opportunities climate change poses to human health. So Stuart's an unusual cat, as you can tell. Let me add a couple other flavors to that. Prior to medical school, Stuart worked as a Knowles instructor, sea kayaking in the lower 48 and Alaska. He has a black belt in judo. He was a bronze medalist in the U.S. Whitewater Open Canoe Slalom Nationals, a commercial fisherman in Alaska. And get this, he earned his master's in fine art at the Iowa Writers Workshop. In fact, his first novel in 1989 about the issue of this conference, climate and health. It's a novel that focuses on climate change and humans. So as I mentioned at the outset this morning, Dr. Harris was an inspiration and a driver for this entire conference. I'm happy to turn it over to him now.
Thank you very, very much, David. That's an extraordinarily a great, gracious introduction that I won't live up to, but I know my panelists will. I'll be introducing everybody in greater detail, but just in brief, wanted to start off by introducing Dr. Kari Nadel, coming to us from Stanford, Dr. Linda Walden, coming to us from her practice in Southwest Georgia, and Dr. I don't see him here. Are you? Oh, there you are. Dr. Ram is a leading expert in New York City, and they each bring an extraordinary insight into how climate change is already directly impacting human health. And we'll be walking slowly through that, having brief presentations, and then to type them in, and we will try to get to them. So I'll start off with Dr. Naidoo and introduce her. She's one of the nation's foremost experts in adult and pediatric allergy and asthma, and we're very grateful for her participation here today. She's an Adasi Foundation endowed professor in medicine and pediatrics, and the director of the Sean Parker Center for Allergy and Asthma Research at Stanford University. Dr. Naidoo grew up in New Jersey. She tells me on a houseboat in the middle of a polluted Mullica River, where her father was acting as a research scientist. So the curiosity about the world and its impact on our health is something that has long and deep roots in her, in that she had asthma and allergies to mold. She's an extraordinary product of my local background here, getting her MD and her PhD from Harvard Medical School. She completed her residency here at Boston Children's Hospital and a clinical fellowship in asthma and immunology at Stanford and at the University of California, San Francisco. Over the last 30 years, I couldn't begin to cover the breadth of her expertise. She has over 200 peer-reviewed publications, has looked at allergies and asthma and the molecular mechanisms underlying diseases. Importantly, she has done groundbreaking work in California's Central Valley examining environmental pollutants and their impact on less advantaged communities. Unfortunately, over the last 2 weeks, she's been deeply immersed in some of the planet's worst air quality as climate change-related wildfires have ravaged California and the West Coast and the mountain states. In the last couple of weeks, in speaking with physicians across California and Washington, Oregon, and Colorado, I've been told repeatedly that they're seeing patients, healthy patients, not people even with underlying lung disease, who are flooding into emergency departments saying, "I can't breathe." And when, as Americans, we have wide swaths of our population saying, "I can't breathe," we need to be paying attention. This is an emergency, and this is something that needs to be addressed now. I would like to ask you all to welcome Dr. Naidoo, and we'll look forward to her comments.
Thank you so much, Stuart. It's wonderful to be here and to give a talk. We are very excited about being able to talk about children and climate change. And this is such a critical issue for all of us because this is our generation now and our generation to come, and we need to think about the future. So I'm very excited about being here today, and thank you for inviting me. I might be thousands of miles away, but we're all on Zoom, and I think we collectively can talk about these issues that are affecting children around the planet. So children and climate change are particularly at risk. Children are the least responsible for climate change, but bear the greatest burden of its impact. The WHO estimates that nearly 90% of the burden of disease attributable to climate change is borne by children under the age of 5 in both developing and developed countries. It will be difficult to overcome these challenges because nearly 20% of the world's children live in extreme poverty, which further compromises their social status and access to care. And pollution not only causes issues in children, but also the unborn. And pollution causes and has been associated with preterm births, as well as lower birth rate, as well as many premature deaths, unfortunately, about 7 million per year. And when we talk about children and poverty, we need to talk about race. We need to talk about environmental justice. And children often bear the brunt of these issues. I'd like to point out that environmental racism is nothing new. It's real. We need to be able to think about this and collectively improve this. Unfortunately, people of color are 2 times more likely to live without potable water and modern sanitization. 56% of the population near toxic waste sites are people of color. My colleague, Nadine Harris, who's currently the California Surgeon General, has developed a wonderful book in the ability to look at stress and calling this ACEs as a metric, adverse childhood experiences. And with that, you can see that children of color are much more likely to have a higher score, which means more stress. And as we think about global climate change and the things that are happening in their health and their environment, this is going to get even worse if we don't do something about it now. The Center for Effective Government reported in 2016 that children of color make up almost 2/3 of the 5.7 million children who live within 1 mile of a high-risk chemical facility in the United States. And I don't need to remind everyone about what happened in Flint, Michigan, and the lead toxicity in those populations, with over 50% of the population who were of color. And with that, I'd like to turn now to California. Like Stuart was saying, over the last 2 weeks, we've had major issues with wildfires. And this is just a graphic to show that with climate change, because there is increased temperatures, because we are much drier, because we still unfortunately are using a large majority of diesel exhaust, and that's affecting ozone and heat and greenhouse gases, we have seen an increase in the millions of acres that have burned up, and that goes up in the air, and that smoke is toxic, and there is no safe distance from smoke, and especially for children. And I want to point out this picture where the child is wearing one of the cloth masks that we've been told to wear for COVID. But unfortunately, this does not do anything to prevent smoke inhalation. There are such fine particles in smoke and oftentimes organic compounds that even the best mask cannot prevent you from breathing in. And so we need to protect children, protect pregnant women especially. Children, unfortunately, are 4 times to 6 times more likely to have asthma than any other population when exposed to wildfires, and only 4 days of wildfires with an air quality index of about 100. So it doesn't take a lot to induce new disease in a child who otherwise is healthy. I'd also like to point out that children and other underserved populations are at high risk. We need to get better at putting emergency preparedness plans together. For example, this is our Paradise Fire, which happened in 2018, where the emergency preparedness plan said to use the local hospital to go to for a clean room and to be safe, but unfortunately that was one of the first buildings that burned down during the fire. So there's hope. I want to make sure that you hear that loud and clear today, that, for example, this is a study where in children's homes we placed HEPA filters in Fresno, California, and Central Valley of California. Unfortunately, they see a lot of wildfire smokes. Indeed, about 1/3 of their year is full of smoky skies from Yosemite now. And because they live close to Yosemite, the Fresno population is at high risk for having wildfire smoke pollution on top of the already polluted skies they deal with. So we put HEPA filters in these homes. You can see that the asthma control test score, which we were using for these families, decreased over time. This is a small study, but again, HEPA filters seem to help in the homes. I'd like to move forward on air pollution caused by bus idling, for example. This was a study that was done in 2015. And importantly, again, after the EPA's National Clean Diesel campaign required cleaner fuels to be used in buses, you can see here in the y-axis, when you're looking at a decrease in the percentage of children that had asthma, that if ultra-low sulfur diesel was used in the buses instead of other fuel sources, there was a 30% decrease in the rate of asthma, especially in the severe children. So again, cleaner fuel means better health in children. And for my inspiration, I was talking to Stuart about how important it is that our own stories, our own populations that we try to help as physicians. My patients over the last 2 weeks have come into the office saying, I can't breathe, I'm coughing all the time, I have so much mucus. And that's because of the wildfire smoke. But what about those populations that oftentimes have to live in that degree of population continually? And they're constantly dealing with asthma, for example, in Beijing or New Delhi. In this respect, a group of teenagers came together, and after seeing our studies that Stuart was mentioning on the molecular changes that were being caused, we think, by pollution and wildfire smoke, the group of teenagers came together and said, we want to help, we want to do something. Let's go to our local officials and try to change some of the laws around bus idling and some of the issues around global climate change. And so this is, I think, a great story showing that a group of teenagers, a group of citizens, just like Margaret Mead said, a small group of people is needed to change the world, and this is what happened. We were able to go to the California Air Resources Board and change some of the vehicular emission standards for the local county and then moving forward in California. So we're really excited about some good news. What can we do as doctors to help children and parents? We need to spread the word. We have to have simple, clear messages. I'm so glad to join my colleagues here, Ari and others, to be able to think about what should we do in the future as physicians, as clinicians. I think as scientists, this is our civic duty to be able to pass these messages on. There's a consensus now among scientists that climate change is real. We've certainly felt it here in California the last 2 weeks. It's bad for people, it's bad for future generations of people, and it is solvable. With that, I'd like to thank the meeting organizers and give the podium back to Stuart. Thank you so much for your attention.
Excellent work, Dr. Nadeau. I'm struck again by just what an honor it is to be here with you. Our panelists have made not just scientific advances and medical advances, but have followed through in changing policy, giving their patients a voice in working towards a better world and a safer, more healthy world. So Thank you very much, Dr. Nadeau. Part of that leadership is seen very clearly in our next speaker. I think sometimes we get in a very dangerous place of thinking that addressing climate and fossil fuel use is a red state or a blue state problem, and it's a universal human problem. And Dr. Linda Walden will be speaking next. Dr. Walden tells me her mission is reaching out to make a difference in rural Southwest Georgia and across the state and nation. And from what I've seen, she's very much doing it. Dr. Walden is a native of St. Albans, New York, and grew up in Sebring, Florida, and was one of the first African Americans to integrate the public school system there. She graduated from Florida A&M University, where she was selected as one of their living legends, and graduated from the Mercer University School of Medicine before she returned to her family roots in Thomasville, Georgia, to practice medicine. Dr. Walden is a visionary, she's a pioneer, she's a catalyst and a community advocate. She has mentored youth to enter the medical field and is a motivational speaker who has broken several color barriers and received numerous honors and awards from local, state, and local authorities. A very small selection of these honors include being named Most Outstanding Rural Practice in Georgia by the Georgia Rural Health Association. She has received the Martin Luther King Jr. Drum Major for Justice and Peace Award, the National Thomas Jefferson Award for her outstanding community service. She's been named by the National Medical Association a Physician of the Year. She's been inducted into the Southern Rural Black Women's Hall of Fame for Economic and Social Justice, is a past president of the Georgia State Medical Association, and is a founder and past president of the Grady County Habitat for Humanity. Dr. Walden was the first African-American chief of staff at the Grady General Hospital in Cairo, Georgia, and the first female physician, either black or white, to establish a private medical practice in Georgia. She's a founding and a steering committee member for the Georgia Clinicians for Climate Change Action, a member of the Medical Society Consortium for Climate and Health. A little known fact is that her cousin was Jackie Robinson, the famous baseball pioneer. She's a member of the Bethel AME Church. And draws deep inspiration from her faith. If you get a chance, listen, you can Google her, and she has a remarkable voice. She's a gospel singer, and her voice is one the nation desperately needs. Dr. Walden, please.
Thank you so much, Stuart. I really appreciate it. It's certainly an honor and a privilege and a joy to be a part of this panel on a topic that is definitely in need of attention to this nation in order for all of us to have better opportunities and better health. And we've got to clean up our climate. We've got to clean up our nation. We've got to clean it out. There's so much that's been going on, especially now because of climate change. Health is the human face of climate change. And it truly is a public health crisis. And not enough attention is being brought to it. But now with COVID-19, also with the police brutalities and murders of Blacks, the time has come for a transformational change in this nation to address the healthcare inequities, the disparities, and the systemic racism that affects us on all levels, all socioeconomic levels, not just health, but our workplace, our schools. Our kids are suffering. We've got to do more, and we've got to make a difference in this country. And that's what I'm trying to do. So as I talk about climate change and public health next, what I want to talk about is letting you know, next slide please, is that climate change is all about global warming. And as you see, there are higher ground ozone layers. There are two types of ozone. There's the good ozone and the bad ozone. The good ozone is the stratospheric ozone that's much higher up, that helps to protect us from the sun rays. However, the ground ozone is kind of what you would look at as smog, fog, and the smog in the big cities, and what you see with all the smoke from the wildfires. That's ground ozone. That is the worst. That is what's harmful. That is what's killing so many people. Over 250,000 people die every year from climate change in America, and over 5 million worldwide. And it's causing the heat waves, the hurricanes, rainfall, storms, wildfires, and it worsens the medical problems that we already are dealing with, so many of our patients. Hypertension and diabetes, asthma, COPD, sickle cell crisis, and added stress. And you know, stress is very common for all of us that we see in our practices. It's about 70–80% of the visits that come to our practice are dealing with some type of stress. And we want to see what we can do to make a difference, to improve all of this. Unfortunately, we're dealing with the healthcare disparities and health inequities that affect Blacks 5 times more than whites, now combined with COVID-19, which is killing the majority of Blacks in this country. As someone mentioned earlier, there are over 200,000 deaths in the United States, and over 6 million people have been tested. You know, so we have got to do more, and we've got to do it now. It cannot wait. This is urgent. A common cold in whites is pneumonia in Blacks. That should not be happening in America. Why? Because many of these Blacks are essential workers. Yes, essential workers are healthcare providers, the doctors and nurses, but I'm talking about essential workers that put food on our tables. The ones that are stocking our shelves with groceries, the ones that are working out on the farms and agriculture, the ones that are working in meat factories and processing them, making sure we have food to eat, the ones who are delivering the packages. And guess what? These essential workers, they don't get paid sick leave, many of them. They don't have healthcare insurance, many of them. Why? Because they can't afford it. And that should not be happening in America. This is one of the richest countries in the world, but yet, not health-wise, we rank number 38. So racial and health injustices must stop, because yes, I do believe Black lives matters. And when Black lives matters, then we can say all lives matter. But until we have these discrepancies, these disproportionate ratios of Blacks and people of color being mostly affected with all of these issues and problems that are going on today, being killed, having these diseases, dying, it is not going to be the same. We have got to make it matter. We have got to do our part. And America, as I mentioned, is is one of the top 12 wealthiest nations, but not the healthiest nations. So if we got so much money, then why aren't we doing more? We need to do more. Next slide, please. Climate change impacts our social determinants of health, and that's where we live, where we go to school, the type of education we get, where we worship, and where we age. Most of our people live in poverty. Many Blacks receive unequal pay, lower income for the same job that whites do, but yet they may get $10,000 and $20,000 less. Even on the educational level, they may have the same educational level, but the pay is not level. They don't get the same. They may have a bachelor's and you have a bachelor's, and you're still going to get, as an African American, $10,000 to $20,000 less. Essential workers, as I mentioned before, those who are keeping us alive, putting food on our tables, they can't telecommute. They can't work from home when they got to put things on the shelves and deliver items to us. And that's why they don't have the insurance. They suffer more as a result. And as a result of suffering, they don't live as long as whites. So we have got to do better in this country. Climate change impacts us because of all the fossil fuels from our driving our cars, the carbon dioxide, the methane, the nitrous oxide, the sulfur oxide, all of that's in the air and it's killing us. The power plants, the wildfires, affecting the air we breathe, the water we drink, the food we eat, and the weather we experience. Next slide. This must stop. As we talk about air pollution and climate change, you have to put it in combination with COVID-19 because that's what we're dealing with now, both. And this is truly going to cause more lives in this country. Now with flu season starting. So please people, get your flu shots. Wear your mask, social distance. Do what you can to protect yourselves so that you can keep your loved ones from getting any type of disease such as the COVID-19, to keep from being hospitalized and dying. The problem we have in America, in addition to the systemic racism, is health inequity. Inequity. Now, health equity is when everybody has a fair chance to live and be as healthy as possible. But we don't have that in America. That's why so many Blacks are dying. It's due to systemic racism, as I mentioned before. Health disparities are the higher burden of illness that people experience, one group of people compared to another. So if you don't have the opportunity to be as healthy as possible, guess what? You're going to be the person who's going to suffer more than others with diseases, and thus the health disparities. And that's how health inequities lead to health disparities. So we've got to do more. We have got to do more to resolve the injustices because Black lives still matter. And until Black lives matter, all lives will not matter. Next slide. We must right the wrongs for the people of color. We need to establish universal health care for everyone. So please, as I mentioned, we've got a clean house. And the first house we need to start with is the White House. So everybody must vote. We've got to mentor our youth to become Black physicians. Do you realize that there are over 900,000 physicians in this country and only 516,000 are white and only 45,000 are Black? And of those Black, there are less than half are men. We've got more Black women becoming doctors, but the Black men are falling by the wayside. We've got to do better. We have got to mentor our youth to go into medicine. We've got to open those doors and give them the opportunities to become a physician. And we've got to start right now. To improve our communities, we need to increase the better health by advertising things that are going to improve our health, the billboards, the TV commercials, things that we need to do to decrease the spread of COVID. We have to have safe parks and walking trails for exercise. We don't have that in many of our Black communities because people are too afraid to go out because of the crime. We need equal pay for equal jobs and sick leave for everybody. Promote jobs. And everybody still, please, you need to get tested. Too many people are asymptomatic walking around here spreading it to others. We need to contact our elected officials on national, local, and state levels to erect new laws and policies for clean energy, decrease emissions, and access to health care for all. Because all of us must become a part of the solution or we are part of the problem. And as I mentioned before to someone just a week ago in talking, if we are not at the table, people, we will be on the menu. So we got to get busy. Next slide. Solutions for our clean air and energy, what we can do. Decrease the fossil fuel emissions, which is what's happening now with COVID-19. We don't fly as much and travel as much. Reduce your errands, maybe to twice a week, because the more gas you burn out there, the more fossil fuels you're putting out there. Maybe consider the next car you buy an electric car. That'll certainly help a lot in cleaning up our environment. For the cars you do have, get those maintenance checks on those cars, change those oil filters and air filters, get your tires checked, because you see when they're not working right and they're all plugged up with dust and dirt, it's just making you burn more gas. Make sure your home is well insulated. get those AC vents cleaned out. Consider buying solar panels. In some states, it's a tax write-off. You can get credits on that. They are expensive, from $5,000 to $12,000 in some areas. We must end poverty. To be one of the wealthiest nations in the world, we should not have this issue. There should be no poverty. We've got to provide training, jobs, and health insurance for people who have served their prison time, and stop penalizing them because they were in prison when they've served their time and paid their fine. Help them get back into the workforce. That's why you see them coming back into prison. Nobody's helping them. They can help clean up this environment. So give them jobs. Walk instead of driving all the time. Buy your LED and energy efficient appliances. That will help save energy. Unplug devices you're not using at home. Use power strips or surrogate strips to keep from having short circuits when there's lightning and thunderstorms. Get green plants put in your household, indoor plants. They help clean up the air, and believe it or not, they convert some of that CO2 to O2. Have your air and water tested. All you have to do is just call your local environmental protection agency. If you don't know, you can Google it, or you can call this national number and they will give you the number locally, and it will tell you your regional office. See what your air quality is. Know that. Know what's going on in your community. And if you see there are problems that look like it's air pollution or bad water, call the EPA, the Environmental Protection Agency. We've got to eliminate the health disparities and bring about health equity for all Americans. Clean air and clean energy. We've got to be responsible to make this happen. Inequality in health is a result of racism, and inequality in wealth, and climate justice. It won't happen without racial justice. Next slide. And lastly, as I close, please make sure you've completed your 2020 census. Many people don't realize how much money can come into your community. If you just complete that and turn it in, it will help improve your neighborhoods, your roads, your hospitals, your schools. It does a lot for your community, but if you all don't fill it out, it's less money coming to your community. Be sure you vote, because your vote is your voice. We've got to unite, black, white, brown, yellow. We have got to come together in this United States of America to make it better. It will not happen with one. It will take all of us. It will take all of us. What affects one of us will affect all of us. So don't just stand on the side. Don't just be a part of the village. Get involved in the village. Let's do our part to unite for a healthier and better America for all generations to come. And let us continue to pray. Pray for our nation. And trust in God, because our lives are dependent on Him. God bless you, and thank you.
Dr. Walden, how one follows that, I don't know, but my heart is with you.
Thank you.
Thank you. Our next speaker is Dr. William Rahm, Bill Rahm. And Bill's been an extraordinary figure contributing to the intersection of climate change and environmental pollutions and health for a long time. He was the Saul, or is the Saul and Judith Bergstein Professor of Medicine Emeritus and in Environmental Medicine at the NYU School of Medicine. He's the former director of the NYU Division of Pulmonary and Critical Care for a quarter century, and former chief of the Bellevue Chest Service, where he trained dozens of pulmonary and critical care fellows and occupational medicine residents and postdoctoral researchers. Interestingly, Dr. Rahm started, as many great physician leaders do, as a wilderness canoe guide from the boundary waters of Minnesota. His dad was similarly gifted. Bill went on to chair the first symposium on the Boundary Waters canoe area on Earth Day in 1970 at the University of Minnesota. In training, he was a fellow of Irving Selikoff, MD, at Mount Sinai, who is largely regarded as the father of environmental medicine He went on to get his master's in public health at the Harvard School of Public Health and was named their Distinguished Alumni Award in 2011. In his work, he founded and directed the Rocky Mountain Center for Occupational and Environmental Health at the University of Utah and served as the editor-in-chief of the highly respected textbook, Environmental and Occupational Medicine. As a leading clinician at New York City's Bellevue Hospital, Dr. Rahm cared for patients with HIV and AIDS, tuberculosis, and occupational and environmental related diseases, including the deadly effects caused by dust toxicity after 9/11. Dr. Rahm helped lead the NYU Medical Center response to the climate emergency of Hurricane Sandy, where the tremendous fragility of our healthcare infrastructure to sea level rise was made absolutely clear. He's the author of National Policy and Law and teaches climate change and environmental health at the NYU School of Global Public Health. If he ever challenges you to a ski race, don't take him up on it. He still races in the Aspen town races, and it's a tremendous pleasure to welcome Dr. Rahm to our panel.
Well, thank you very much, Stu. I'm going to share the screen and try to bring up some slides. I'm going to address three areas in my few minutes. They have high attribution to global warming. They're heat, air pollution, and extreme weather. From the National Weather Service, we now have extreme heat as well as flooding and tornadoes and hurricanes as the leading cause of death. Secondly, you can see that the days per year that are hotter, for example, above 95 degrees Fahrenheit, looking at the next 2 decades, there are areas across the globe that are going to get hotter. Third, you can look at heat from the standpoint of heat waves. The most famous one was in August 2003 in France. The mean maximum temperature exceeded the norm by 11 to 12 degrees centigrade on 9 consecutive days, leading to 15,000 excess deaths in France and 32,000 in Western Europe, with 70,000 total across the European continent. The increase in deaths were related to heat stroke, hyperthermia and dehydration, chronic respiratory disease, and stroke. When I was an intern in July of 1971, I was assigned to the emergency room. In my second week of internship, a mid-aged white male came in, obtunded, and the nurse took his temperature, and it was 107 degrees Fahrenheit. This was my first case of hyperthermia. We dumped ice cubes on him, started an IV, and tried to resuscitate him, but he died. I was exposed to that event in the extreme heat of Sacramento and Central Valley, California, and it made a lasting impression. Fourth, there's something called an urban heat island. Over cities, it's hotter because of the impervious surfaces. And if you move forward under higher emissions, the whole country is going to be experiencing increased surface air temperature. As John Holdren mentioned, if you factor in humidity and look at the wet bulb global temperature exceeding 33 degrees centigrade, which is thought to be the level of safety, we already have more than 250 million people across the globe exposed to this level at 1 degree centigrade increase. If we go to 1.5 degrees centigrade from global warming, that 250 is going to double to 508 million people. If we go to 2 degrees centigrade, which we may well do by 2060, we'll have 789 million people exposed to this WBGT temperature above 33 degrees centigrade. If we hit 3 degrees centigrade, which we very likely will do by the end of this century, 1.22 billion people will be exposed to this severe heat more than 1 day per year. Well, heat isn't equal to everybody. This is from Jeremy Hoffman at the Museum of Science in Richmond, Virginia, published in the famous New York Times on August 24th, that Richmond has areas that have greater heat than other. And you can see on this slide that the right-hand side is bright red for high heat, and the blue is cooler. And if you look on the right-hand side of the slide, you'll see that the areas that have red high heat are also shaded in red. This is from the redlining map in the 1930s after the Fair Housing Act was passed, and government bureaucrats outlined areas of low income in red. The mean income there was between $250 and $750 a year. And in yellow are similar declining neighborhoods, and blue are up and coming neighborhoods, and the green were good neighborhoods with a income of $7,500 per year back in 1937. So they wanted to guarantee mortgages under this act. And they looked at the red, and that was 95% black. They looked at the green, that was 95% white. And this has persisted and caused systemic racism for almost a whole century. If you look at the further maps, the redlined areas had fewer trees. There's less green in this area. And on the bottom right, there's more dark areas suggesting parking lots and impervious surfaces. So this has created racial disparities. Those disparities are not only in heat, but they're also in air pollution. So this is a slide looking at PM 2.5, which we've already heard about. And in the United States, the average concentration of PM 2.5 is higher, where it's red and yellow on the eastern half of the country, and also in California in the far west. In the upper right, you can see that PM 2.5 has been declining since 1981, every single year except 2018, which went up 5%. On the lower left, with the arrow, you can see some of the racial disparities. This is from a study published July 31st in Science by Colmer. You can see that there is a line of identity and all these dots, with the x-axis 1981 PM 2.5 and the y-axis 2016 PM 2.5. And you can see that these are 65,000 census tracts looking at PM 2.5. If you're in a very clean census tract in 1981 with very little pollution, you're still in that same census tract in 1981 with very little pollution. If you're in the census tract that is the most polluted in 1981, you're still in that same census tract that's most polluted in 2016. So we have gone not very far in 36 years. In the middle figure, you can see the change in the pollution in these census tracts. And in the dirtiest one, they actually had the greatest actual decline in PM 2.5. So that's good news. But the bad news is that the relative ranking of those 100 census tracts, the dirtiest one has persisted to be the dirtiest one in 36 years. On the right is data from Dye in the New England Journal published in 2017 about mortality from 22 million Medicare deaths between 2000 and 2012, looking at PM 2.5 by areas of residence. And you can see that there's a very steep curve in the hazard ratio for mortality from cardiopulmonary disease and exposure to PM 2.5. As points of reference here, at 15 micrograms per meter cubed of PM 2.5, that's the standard under the George W. Bush EPA. They didn't lower that, even though I lobbied the EPA administrator as part of the American Thoracic Society to try to lower it. But under President Obama, he did lower this annual mean standard to 12. So you can see 12 is safer than 15, but it's still a long ways from being safe. The WHO recommends 10, and more recently, under the last 5-year review of the NAAQS, or the National Ambient Air Quality Standards, between 10 and 8. there was no change from that standard. Lastly, I'm going to talk about extreme weather. This is Hurricane Sandy and NYU, where we all are faculty. On the left is Tisch Hospital being evacuated on the night of Monday when the hurricane struck with a 13.5-foot tidal surge that inundated the Bellevue basement. Here's the water coming into Bellevue. The basement is where the elevators went, and they were shorted out. The pumps for the diesel to keep the lights on was shorted out, and brigades were formed by doctors to bring diesel up to the 13th floor, and the pumps for water to bring water up to the 22nd floor to flush 1,000 toilets was wiped out. So the hospital had to be evacuated 2 days later. As head of a training program, all of a sudden I had my 2 main hospitals with no patients to train my doctors. I had no place for my doctors to see their clinic patients, and we had to meet, we had no place to meet, so we met in local bars, and we developed programs at other hospitals for our trainees, and we developed off-site clinics to see our patients. We had to close down all our laboratories. All the transgenic mice at NYU were in the basement. They were all drowned. NYU lost $1 billion and was rewarded that from FEMA. Bellevue, $350 million to change its electrical system. So we were out of sync for 6 months. This was extremely stressful to everybody. I ended up having a cellulitis of a leg that caused me to limp. So I went to the orthopedist and he gave me some antibiotics. A week later, I went back to him and said, what are these little red dots all over my skin? He says, you have, looks like herpes zoster from your stress. So I went to the dermatologist. He said, yes, you have disseminated zoster. Get the hell out of here. Go home, take acyclovir. So I responded to the doctor. So these things cause stress. So I was a climate patient myself. I'll end with one sentence about fires. This is the Wetstein paper in 2018 that looked at the wildfire smoke in California. They had 8 smoky sheds that they looked at, and they got data on emergency room visits by zip code in those 8 fire sheds, and compared them from May to September in 2015, and found significantly increased emergency room visits for ischemic heart disease, dysrhythmia, heart failure, pulmonary embolism, stroke, and respiratory conditions on the day of the smoke or even 1 day later. And they compared this to acute appendicitis, and especially individuals more than 65 years were susceptible to this smoke. And on the bottom right is that smoke reaching Washington, D.C. and causing haze over the Washington Monument. So thank you.
Beautiful. Thank you very much, Dr. Ram. I think it's worth everybody's listening just to make sure we hear loud and clear. Both Dr. Naidoo and Dr. Ram now have spoken to how climate change can suddenly remove healthcare facilities. So we can think we have access to hospitals and that we've built robust systems. But if suddenly climate change can render those unavailable, the best technology in the world is lost, and it's kind of a scary time. So with less felicity probably than many of our panelists, I will try to run through my slides. So I'll be speaking to climate change as the healthcare emergency it is. So I'm an attending physician at Massachusetts General Hospital. My daily practice, which included the weekend and recent overnights, is the ability to recognize emergencies, which are circumstances that call for immediate action. A common plight may be, I can't breathe, and that's one that kind of gets our attention, and as citizens should certainly get our attention. The scientific data have been very clear for a long time, at least 30 years, that climate is warming and that it's due to human influence. You can see Dr. Hansen there giving his testimony in the summer of 1988. It was quite compelling then, to the point that I, again, focused my narrative limited abilities on trying to understand just why we didn't seem to be able to move forward and away from a fossil fuel-based economy. The medical data are equally clear, as have been very well discussed by our other panelists. There's obvious heat stress injuries, there's cardiovascular disease. The independent use of fossil fuels directly increases rates of disability and disease and death by asthma, by strokes, by heart attacks. And lastly, it's become quite clear that the least affluent of our patients, who have contributed the least to climate change, are being most negatively impacted by it. So climate justice is very, very real. And that climate change rather is very clearly a healthcare emergency. My patients now are being impacted by climate change and fossil fuel use, and that it is time for action now. 30, 40 years ago, we had a little room and we could think about writing stories. Now it's time to act. And we need to get to a world and a country where we don't have large portions of our population saying, I can't breathe. I'm sometimes asked what the role of healthcare providers is in climate change. And I think we have obvious, unique scientific and medical expertise. And that's something I think we depend on and maybe do a little bit less good a job at using it outside the hospital than we could. I think a special power that healthcare providers have that they don't recognize is that we are a story-driven profession. If I could be given just one tool to help my patients to make a diagnosis, it's to have them talk to me, to have us be able to communicate and to understand what's going on. It's really the gold standard for deciding what other medical tests we might need to send to make a diagnosis. And we're expert communicators. Everyday healthcare workers communicate very complex scientific data to their patient in ways that they can understand and in ways that the patients are in turn motivated to improve their health. And this is a rare quality. I have extraordinary colleagues who are PhDs who know the data left and right, but it's that communicating the data, giving voice to the data, that's a unique ability of healthcare providers to forward that progress. Part of it is forwarded by the fact that we're a trusted source of climate change and health data. The public and voters trust us, and with good reason. We've given our lives over to acting in their best interests, and that's reflected in their trust. Another point that I think is absolutely critical is that healthcare is both deeply personal, but it's also universal. And using the lens of healthcare makes what can seem distant, maybe DC-based policy decisions absolutely real to people and visceral. And using our patient stories and making sure that the experiences of our patients are known to policymakers can make very clear that energy policies can be either life-giving if they're low carbon sourced, or potentially life-threatening if they're fossil fuel-based sources. Another way that health, I think, is vastly underrated is it's an extraordinarily effective fulcrum for rapid policy change. If you would have told me a year ago that the very well-established and legacy policies would be as upended as they were by a simple virus, I think I would have looked a little askance at you. And here we're altering the basic mechanism, the biosphere upon which all life depends. And so to not see that as a way to rapidly change established systems, as I think we've proven differently. So in closing, I think the prescription for change is pretty simple, and it's been spoken to by each of our panelists much more eloquently than I. But for health providers and for public policymakers, and for the voting public to know that climate change is a healthcare emergency. We had time to act in a graded fashion in the past. It's time to step up our game and to act now. I think, as Dr. Bernstein and others have made clear, in the Attorney General, Attorney General Healey made clear, climate change policy is healthcare policy. As physicians, this is our responsibility. And our patient stories matter tremendously to informing policymakers and leaders that this is something that needs to be dealt with right now. As healthcare providers, we have a tremendous influence, and I think it's absolutely critical that we use it and that we advocate for a low carbon economy in an apolitical manner. I don't see this as being political at all. This is just good health policy. It's prudent, it's just, it's fiscally efficient, and it's life-saving. And the changes that we can make towards moving towards a low carbon economy are long overdue and what we should be acting on. I think we've been enthusiastic enough. I don't know that we have a great deal of time for a conversation, but I would love if, since we heard from her last, if we can start with Dr. Naidoo, just tell a very brief story about how climate change has impacted one of your patients.
Yeah, well, thank you. I recently took care of a young girl who was 5, who came into our emergency room, and she had never had any wheezing or asthma before, but unfortunately she had been exposed to wildfire smoke, not up close, but this is hundreds of miles away, and here in the Stanford area we've been exposed, all of us, and children I knew had a 6 times higher rate of getting asthma de novo when it comes to wildfire smoke exposure. So it had been about 4 days of our heavy skies, our orange skies, which you all saw on the news. And she was one of many children that were coming into the emergency room with asthma. And so she couldn't breathe. Her parents were extremely worried about her, and they asked, why is it that she's getting this and not us? And that's because, unfortunately, children are at a much higher risk. And the other issue is that a lot of the N95 masks are not specifically made for children's mouths yet. And so we need better ways to mitigate and adapt to wildfires, especially in children. She did get better, thank goodness, but we had to work very hard to get her out of status asthmaticus. And that was sad to see, but she was one of many. I think my other story is an elderly man who's 65, otherwise completely healthy, runs all the time, works out, didn't work out during the wildfires, but then had a stroke. And when his wife asked, why did he have a stroke? It pains me to say that because the pollution gets right into your bloodstream, and people who are elderly already have a higher rate of having blood clotting issues, especially stroke. And so for him, he had no other risk factors except the fact that he was exposed to wildfire smoke for 5 days in a row, despite having all the appropriate filters in his home and despite wearing a mask outside. So these things are really worrisome to me as a physician, and we need to act on these things and to help the planet get better so our patients can get better.
Thank you very much, Dr. Naidoo. In deference and respect to the people we have on the line, I want to end in a timely fashion. We'll look forward to future occasions where we can hear more from Dr. Walden and Ram and Naidoo. They're important leaders in bringing this forward. I want to thank each of them for their tremendous dedication and for their willingness to step in and to help protect their patients. With this, we'll conclude the conference. I want to be sure to thank Melissa and David and Ricky, their extraordinary staff, our panelists, both in the first and the second panel, and the attention of Attorney General Healey. I seem to want to make her a physician. I want to thank our audience who have joined us and are taking this fight forward. And I hope doing it with the same spirit that Dr. Naidoo spoke to, of hopefulness, that this is inevitability. This is going to change. and we're going to do it together. We'll be emailing you a link of a recording of the event shortly. And I think the future is going to look back at us in 2020 and be shocked at how we allowed delay to continue. And I think they'll be pleased to know that now we've recognized that it is time for action, that climate change is a health emergency, that climate policy is health policy, and that we are well overdue in our transition to a low carbon economy, if only for the patient's health. It's our responsibility to our current patients and to future generations, and we're going to see it through. Thank you very much. Take care.
Thank you.
Thank you all.
Thank you.